Hello, dear listeners. Welcome to another episode of Follow Your Path. My name is Abdul Abid, and today we will be talking to Dr. Sanjay Mukhopadhyay. He is a thoracic pathologist at Cleveland Clinic. My co host Meredith Herman won't be able to join us today because of travel. Welcome to the show, Dr. Mukhopadhyay.
Thank you very much, Abdul. Really glad to be here.
So, starting off, can you tell us a little about yourself, like where you grew up, where you went to medical school and residency, and how did you end up in thoracic pathology?
Yep, I was born in India in New Delhi and lived there pretty much all my life, and went to medical school there at a college called the Maulana Azad Medical College, which is part of the University of Delhi. And then I went to through a sort of circuitous route, I eventually ended up in pathology at the All India Institute of Medical Sciences, which is also in New Delhi, a very big, famous place. That's where I did my first pathology residency. So I consider that my true sort of training institution, when I was really a trainee. And then I did came to the US, and as you know, when you come to the US as a foreigner, you have to do it all over again. So I did another residency, and this time was at SUNY Upstate, which is the State University of New York, Upstate Medical University, which is in Syracuse, New York. It's in the northern part of New York State and a very cold and snowy place. But at that time, just to give you some background, I was interested in GI path. I'd done my thesis in my first residency on celiac disease, so I was really interested in that. I'd worked on that for 2 years, and I was also interested in heme path. That was kind of my interest for a long time. I really loved heme path. But in terms of mentors, I was looking for somebody who was really, really top notch, nationally renowned or internationally renowned. And one of the faculty at that time was Dr. Anna Louise Katzenstein. So she was a very, very famous senior lung pathologist who had done some of the most seminal work in lung pathology. So she's the person who described RBILD, who created that entity,
Mm,
RBILD, NSIP that was created by her, and some of the very, very basic entities, allergic fungal sinusitis, in the
mm,
ENT realm,
mm,
was that entity was created by her. And then a lot of the stuff in ILD and even some tumor pathology was created by her. So when I met her and I realized what level of pathologist she was, I just switched my focus. I said, this is a chance that I'll never get in any other place or ever get in my training. So I switched. I started doing um, uh, projects with her, and then I started looking through her consult cases, and that's when I really got hooked. I said this is just another level of path, which then shifted my focus. And for fellowship, she asked me to go to Mayo Clinic, or at least to try to go to Mayo Clinic
right,
for my fellowship. And at that time, things had already, I had already decided that this was going to be my path.
right. Nice, wonderful. And you just answered my next question. Like, what was there a particular faculty member or mentor that inspired you to choose thoracic pathology? Was
Yes, by Dr. Katzenstein,
right,
I and above.
right, right.
I had actually gone to Mayo Scottsdale to do their little observership kind of thing that they
Hmm.
offered. I got that as part of a travel award through the Pulmonary Path Society. But at that time, I had already learned all of that stuff through Dr. Katzenstein. Through looking through her consults and doing
Hmm.
that for maybe 2 years, going through all her stuff. All the old cases in
Right.
the archives. So none of that stuff was new to me, what I learned there at Scottsdale. And then when I started my real fellowship, which was at Mayo Rochester, again, none of that stuff was new to me. So I didn't learn anything that I didn't know before. It was just a lot of repetition of those things. So I
Right.
saw where I had seen two before, now I saw 15. Or, in tumors, lots of things that become bread and butter later on: mesotheliomas, sclerosing
Mm, mm.
pneumocytomas, this and that. I saw a lot more there than I had seen before. So it sort of expanded my repetition of the things that I'd learned. But I really considered the way that I learned lung pathology was by looking at Dr. Katzenstein's consults. That's how I learned the basics.
Nice, nice. So, can you share a little bit more about her? Like, how was she personally? Like, how was your interaction with her? Like, was she did she do like double scoping with you? Like, what was her approach towards mentorship?
Yes, very unconventional, I'd have to say. Dr. Katzenstein was also mentor to Dr. Jeffrey Myers, who's now had been chair at Mayo for many years and was chair at Michigan. So he was her kind of, I think, the first mentee. And her approach was very unconventional. It was not like it was not at all spoon feeding you,
Right.
where you, like how I do now. Like, when the resident comes and sits in my office, I teach them one on one. I try to explain things in detail. It was not at all like that with her. With her, it was more like, you go and look at the cases, and if you have a question, come back to me. So it was really like she expected you to learn on your own,
Mm.
which I think is a very sort of a old fashioned, but I think much better way to to learn. It's like to put some expectations on the trainee. Say
Mm.
you put some work into your own.
Mm. Mm.
And I think what happens with that is, because it is self directed learning, you have much more to gain from that, much more skin in the game, than if somebody is just spoon feeding you everything. You learn some and you discard a lot of that.
Right.
It's
Right.
not quite the same thing,
Mm. Mm.
as if somebody tells you. So that was one thing. She would say, look at my consults, and if you have questions, come back. And of
Mm.
course, if there was a question, you would come back. But she was very senior, very intimidating as a personality. That's another thing that's very different. When my level and her level was so different, that I was very much intimidated.
Mm.
And it's very different than my trainees, where they can come and ask me a
Right.
question, and they can challenge. And it's very different when someone that at that age and level of seniority, and you're just starting off your career.
Mm-hmm.
There's a lot of imbalance in.
Yeah. Yeah.
The other thing she did was, she was a fantastic mentor in terms of writing papers.
Mm.
She taught you how to think clearly, how to come up with a clear plan, how to honestly report findings without exaggeration. Because I came from India. My writing was very flowery.
Mm.
I tried to make things which maybe didn't exist. But she cut it down brutally. Her manuscript editing. She taught me how to focus on what really is there, and not to make more than what is really there
Mm. Mm.
in results. So she was a very brilliant mentor when it came to writing papers. I just knew, when I was writing a paper with her, that no matter what I wrote as my first draft, it would come out as a shining diamond, when she was done with it. But she did not do it herself. So she would make little notes in the
Mm.
in the corner of your manuscript.
Mm-hmm.
You had to give her a printed copy of your
Right.
manuscript. She would make notes in the corner. You had to change it, and then she would keep on sending you back.
Mm.
It was not first draft, second draft. It was 20th draft, 30th draft,
Oh,
40th draft. She would keep on sending it back brutally, and you had to make the changes. It was
oh,
no, like, I don't know how to take pictures.
right.
I don't know how to do this. Nothing. You learn it on your own and do it.
Wow.
So it was brutal. It was very, very hard on the trainee, but it taught you, you know, the nuts and bolts of how to do it. And she just, by example of her writing, she would teach you how to write a paper in a
Right. Right.
clear, concise, non-exaggerating way. And just that was just a brilliant experience to learn that from her.
Oh, wow.
Yeah.
Oh, wonderful. So, about thoracic pathology, let's talk a little bit about thoracic pathology. So, you have been practicing for many years. In your opinion, if you had to talk to a medical student, such as Meredith, who's not here today, or a junior resident, first year resident coming in 3 months ago, what would you tell them about thoracic pathology? Like, what makes it unique? What makes it different than, let's say, other GI or hempath, for example?
Yeah. I think all specialties have their, so I really don't want to knock any
Right.
specialty. As I told you,
Yeah.
I liked GI, I liked hempath myself, and all the specialties have something great. But I think if you had to compare lung to them, right, and say how it's different, so there's a couple of things about lung. One is that there are very few pulmonary trained specialists in this country. Very few. I mean, there are a handful, maybe a dozen, that are subspecialty trained thoracic pathologists that have gone to a good subspecialty training and done it. And there are also very few training programs that actually offer subspecialty training in lung pathology. So you are, compared to, let's say, GI or GU or hempath, you are a very rare breed. So it goes both ways. There are very few places that need a thoracic pathologist, because very few people have the volume that justifies that. but there are also very few people to pick from. So you are one of very few. If a new thoracic place is opening a thoracic program, they have maybe 12 or 20 people to choose from. They don't have 100 people to choose from
Mm-hmm.
as compared to other specialties. So that's one very distinct thing about thoracic pathology, that it's a small field and there are very few subspecialists. So the group is small. The second thing about thoracic pathology is that although lung cancers are, I think, relatively easy to learn. I think any resident who is good can learn lung, how to report lung tumors and lung. But interstitial lung disease is very difficult to learn. It's a very intellectually demanding field. There's also radiologists and clinicians involved who have their strong ideas on how things should be, and every lung pathologist has their own ideas about how things should be. So it's very contentious, lots of fighting, lots of debate, and you have to be really at the top of your game intellectually to handle that. You can't just, it's not just show me one tubular adenoma and then I know how to diagnose the others. It's not like that. You have to be able to wrestle with um, how to interact with radiologists, clinicians, when to fight back, when to push back, when to accept the radiology or clinical scenario as superseding the pathology. So it's very complicated. It's
Mm-hmm.
not an easy thing. And I think that intimidates many people. They don't want to do that because it's very intimidating. But for some people, that's a challenge that they want to take on. They
Yeah.
feel, oh, this is so interesting. There's so much going on here that I want to be part of it. So I think that's, in medical lung disease, that's one really cool thing. The other thing in lung that I think we have is very cool: lots of infections. So we deal with lots of fungal, mycobacterial infections, other types of infections. That's very, very satisfying to diagnose, very good for the patient. I feel that's a very high yield thing in lung path. And like Abdul, there's also lung transplant pathology. Now, I myself don't think lung transplant pathology is too very challenging or much of anything, but I think that's another facet of lung pathology that's worth learning for new trainees. And I think
Mm-hmm.
that's one way in which we are different from other
Hmm.
specialties, some other
Nice.
specialties.
Yeah, that's great. So can you share a case, and you have been practicing for many years, so one particular case that you think you found the most interesting in your career?
Yeah, I remember one. There's a friend of mine called John Gentry. From We were fellows together at Mayo Clinic, and this is just after. So, what my first paper with Dr. Katzenstein was on aspiration of food and other particulate material into the lung. That became a very highly cited paper. It was quoted by Dr. Colby at the USCAP meeting. It became very well regarded, but at the time I didn't know what an impact that had. Like, because I had just written it. I was a resident who had just become a fellow. I was very early in my career, and I didn't know how much of an impact it would have. So this one time I was just sitting at my desk as a fellow, in Rochester doing my cases, and John came up very excited, ran up to me. He said, Sanjay, look at this. So he showed me the case, and I immediately recognized that it was aspirated food was in the lung, and it was causing a kind of interstitial kind of picture, uh, with granulomatous disease, old degenerated particles, which the person who had sent the case had not recognized, because it's
Mm,
a challenge to recognize
right.
them. So I was very happy to see that, and he said, "Look." He held up my paper. He said, "It's exactly like you said in your paper." And that was a kind of joy that it's very hard to describe. When you do a thing that's relatively new that people have not recognized before, and when somebody else recognizes it in a real case, then looks at your paper and finds that there's an answer there, that's just a joy beyond things I can describe. It's because you make a difference in the real world to
Yeah.
somebody else,
Mm-hmm.
in a practical way. And your paper is not just some pie in the sky thing, it's something that is really usable.
Mm.
I think that case really brought home that to it. Actually, I have had him made a recut of that, so I
Right.
could keep that, and I still have that as one of my prized possessions. Of course, that happened many, many times over the years after that, many, many times. But that was the first time that I saw somebody else benefiting from a paper that I did, and remember this case for that reason.
That's great. So you just mentioned that that made you really happy. So coming to your job, like what is the most gratifying aspect of what you do as a thoracic pathologist?
Yeah, there are many things. Giving a quick, efficacious diagnosis, with a quick turnaround time that's accurate, is something that makes me very happy. When in consult practices, I pride myself on that. Um, when somebody sends a consult case, not just to give a accurate diagnosis, all good lung pathologists can come to an accurate diagnosis, but to do it quickly, to do it in a time period where the clinician, the patient are not racked by anxiety about waiting for their results. Try to move things quickly and also do it in an efficacious, accurate way. But I think one of the coolest things, Abdul, this is not really well understood, is that not just lung pathologists, all pathologists can render a couple of types of diagnosis. One is what I call like the rubber stamp diagnosis, which is what the clinician is thinking is the answer, right? So if you clinician thinks it's malignant, you tell them it's malignant. You tell them what kind of malignancy. That's a very important part of our job, but it's not that great. They already know what it is, and you're telling them what they know is right. It's fine. It's satisfying, but what I find really satisfying is when they're going down the wrong path and you completely change that with your diagnosis, right? So they are completely going down the wrong path based on clinical high resolution CT, pulmonary function tests. It's all going down the wrong path, and you look at the pathology and you go, no, that's not the answer. The answer is smoking related interstitial fibrosis or particulate matter aspiration or iron pill aspiration into the lung, or some kind of granulomatous lung disease when they're thinking malignancy.
Hmm.
That's what gives me the greatest joy, is when pathology completely changes the course of clinical and radiologic events and completely goes the other way. I think that is something that trainees take a while to understand, is that you need to be so good or so confident in some situations that that even if you're going against the grain of the clinical and radiologic findings, that you are right.
Hmm.
That's what gives me the most joy in any part of lung pathology.
Oh wow. Oh, that's great. Yeah, I mean, definitely that also plays into the fact that pathology, like you are rendering patient care and you are part of the team. Like you're not just like someone who's sitting in a basement looking at slides. You're also an active part of patient care team who is basically going to change that direction of whatever way treatment or prognosis is going to go. So that is
Correct. Can I
definitely,
mention one more thing, Abdul? So,
yeah, sure.
there is this people stress nowadays clinical pathologic correlation, correlate with this, correlate with. I understand why they're saying that. You must be cognizant of what the clinical setting is and the radiology is. But I think what trainees take it to mean is that you should try to make it fit, the pathology fit with the clinical.
Hmm.
And I think that is actually a big disservice to the patient. If you're just trying to, so in a way that is cheating, you're trying to look at what the answer is and trying to make your thing fit with the answer. That is not what clinical pathologic correlation means.
Hmm.
What it means is you try to understand how the pathology fits into the larger picture of the clinical and radiologic setting, and if it does not fit, you should have the honesty and the integrity to say that.
Hmm. Hmm.
You should have the, so that takes a lot of experience, skill, and I think trainees need to be taught what exactly it means to do clinical pathologic correlation. It just doesn't mean just looking at the clinical, reading the note, seeing what they wanted to call it, and calling it that on path. That's not what it means.
Oh yeah, that's a very good point. So if someone is interested in becoming a thoracic pathologist, what is a pathway? Is there a fellowship? Is there a board exam? Like, what's the scenario?
Yes. There are. We don't have a boarded fellowship. That's the difference from, let's say, hempath.
Hmm.
Places, the things that have a boarded fellow, hempath, neuropath. The things that we know that have a well-defined fellowship. Lung fellowships are still non-boarded, so people often combine them with a search path fellowship. So Mayo does that, for example.
Hmm.
Will combine it with a search path fellowship, or combine it with cardiac or something like that. But there are places, Mayo Clinic Rochester is one of the best ones, that offer um, these pulmonary pathology focused fellowships where the majority of your work is pulmonary pathology.
Hmm.
So if you're interested in thoracic pathology, that's what you should be looking out for these pulmonary pathology fellowships. Memorial also offers that, and there are other places that also offer these pulmonary pathology fellowships that will train you for a year in, in a very focused way in
Mm,
pulmonary pathology.
mm,
It is, I have to say, a much less developed kind of fellowship than many other fellowships
mm,
are, that have been going on for decades. They
mm,
have their boarded systems. So we are behind in that way. But there are certainly these high level, fellowships at tertiary care institutions are very, very helpful for developing expertise in the field. You can get grandfathered in, you can say, oh, I learned from so and so, and I just looked at their consults. But it does help to have a structured fellowship.
mm,
So I
mm,
would suggest to people to look out for those. One really good site to look at is the Pulmonary Pathology Society has a list of all the fellowships that are
mm,
available. So you
mm,
just go to the Pulmonary Path Society website and just click fellowships, and you'll get the entire list.
mm. Oh, that's great. I think that's a good resource. And you mentioned earlier that you went on an observership that was funded by the pulmonary pathology. Do they still do that, just out of
Yes,
interest?
yes, that's another nice thing that the Pulmonary Path Society does, PPS for short. What they do is they will fund, sometimes they do travel awards, they'll do other kinds of awards for trainees, and sometimes those awards are actually sponsoring a short training session with an expert at some
Mm,
institution. So
mm,
for me it was Mayo Clinic
yeah.
Scottsdale. That was at the time when Dr. Colby, Leslie, and Tazlar were there, so that was a big draw to go there and
Mm,
do a little few weeks with them.
right. Yeah.
So that kind of thing is a valuable experience, if you can get a short sort of observership. It's not really a residency in any
Yeah.
way, it's
Yeah.
not a fellowship, but it's some sort of an observership with a well-known expert. It actually goes a long way because you get to see for a
Mm,
very short period an intense focused experience in lung pathology. You can go through their training sets. Many people nowadays have digital sets, and then the expert can give you one-on-one advice, which would not be possible in a general search path kind of environment.
yeah. Yeah.
So yeah, the PPS does that, and many people I think offer these kind of short stints that are
Mm,
very
mm.
helpful.
Oh, wonderful. So this kind of dovetails into my last question. What advice would you have for someone, a junior resident, for example, who's interested in pulmonary pathology? What should they be focusing on while they're a resident?
Yeah, one thing that I was in a sort of unique position because at the residency that I was at, there was already a thoracic pathologist
Yeah.
there. If you don't have a thoracic pathologist at your institution, I would say the best things you can do are, first of all, read intensively about lung pathology. So
Mm,
read new articles that come out, read a lung pathology textbook from
mm.
anybody, somebody
Right.
who's a good author. Read through the pathology textbook. Try to make an extra effort to look at lung pathology cases at your institution. So
Mm,
not just when you were
right.
there for 2 weeks, but
Yeah.
all,
Mm,
if there's a teaching set, if somebody in that particular place is an expert,
mm.
even if you have a general search path place, generally there's one person who's like the lung
Yeah.
person.
Yeah.
So go to them and ask them if they have interesting cases or teaching sets and go through that. And then another thing you can do is reach out to experts. Nowadays Twitter is very easy to reach out to experts and say, hey, do you have an observership? Can I come and learn with you? Can you mentor me in some way? I think that's a good way to reach out to people. And then finally, try to be academically productive.
Mm,
Even if you write one good paper or two good papers during your residency, that's a very big thing that you can then show as a mark of what you have done when you're looking for fellowships.
mm.
So, and then finally look for a good fellowship, for a good pulmonary path fellowship. I know pulmonary path fellowships are always looking for good applicants, so
Right.
it's not so competitive that you can't get in. So
Mm.
it's a good idea to look for that kind of training experience, I
Oh,
would say.
great. Great. Thank you very much. Yeah. Also, you just mentioned books, and I should mention one of your books, which I found very useful when I was doing some thoracic bath at my fellowship. So thank you for that.
Thank you
And
for mentioning that. Thank you.
and so that's our show today, folks. You can find Dr. Mukhopadhyay on Twitter, on Instagram. He has some great stuff on YouTube. He's also on Kiko. His Twitter handle is at smlungbathguy. Thank you very much for listening to us, and we'll be back with another episode soon.
Thank you, Abdul. Hope your listeners find this helpful.
Yeah, me too.